Our next presenter is Eric Ruthford of Seattle, Washington. He's a preemie parent and an author, former financial manager of Raphael House in San Francisco, a homeless shelter. Delighted he's taken time out of his parenting duties to be with us today to present on Seek Out Motivations, Improving Antenatal Counseling of Preemie Parents When Infant Death is Likely. Please welcome Eric.
And I've got a presentation I'm going to get started here, and I'm hopeful that the computer... All right, well, to provide a little more introduction of myself, again, my name is Thomas Eric Ruthford. I'm from the Seattle area. And I'm writing a book about our experience of having an extremely premature infant. And there are several priests, whom some of you may know, who were heavily involved in the process. My spiritual father is Father John Pierce. My father-in-law is Father David Moser of Boise, Idaho. And my godfather is Father Barnabas Powell of Kirkland, Idaho, who, for the Ancient Faith Radio listeners at home, I should point out is a different person than the one who has the podcast. Also, Father Alex Kotar's church was just up the street from the hospital, and he paid regular pastoral visits and brought relics of St. John of San Francisco, who fell asleep at that church in 1966. And my ability to attend this event was the result of several fundraisers that our church put on, and so I want to say thank you to all those people again. So to get this story started, I'm going to start with a video here. It's about 40 seconds long. I'll let you watch that. He's got him off the dopamine now.
That's what Mary was saying.
Yes, and that means his heart is keeping his blood pressure up at the right level by itself.
Okay.
And his blood is a little on the acidic side, so giving him sodium bicarbonate for that.
Already he's getting baking soda, huh?
Yeah, and he's been getting a lot of transfusions lately, just because, well, his body only has about 3 tablespoons of blood in it.
Is that all?
Yeah.
3 tablespoons, wow.
Yeah.
This video was taken when Gabriel was 1.5 days old. The voices are mine and my father's. Getting to this point was quite a trial. 9 days before Gabriel was born, Miri, my wife, checked into the hospital with preterm labor at 21 weeks and 4 days of gestation. She was offered an abortion several times, but she refused. The goal of the new treatment was to make it to 24 weeks, at which the baby was going to have a 50-50 chance of survival. At 22 weeks and 6 days of gestation, Mary's water broke. At that time, the hospital had a limit of 23 weeks and 0 days before it would try to save a preemie. We had a visit from a neonatologist who said, "I don't recommend that babies should be treated at this stage because the results are so poor. If you give birth after midnight, I'll be the one who comes and does the resuscitation, but my heart won't fully be in it." And this is the ethical dilemma that I want to talk about. How can you have the parents and the doctor on opposite sides of a decision whether to treat? And how can you have treatment withheld against the wishes of the parents? With this presentation, I am going to suggest some better ways of navigating the dilemma that can be used in hospitals. Some of these are tools for doctors and nurses. Some are for priests and chaplains in their pastoral care. I believe that doctors should seek out the motivations, not just the wishes, of parents who are anticipating the birth of a critically ill newborn in helping them determine a path of treatment. I also believe that priests should take special care to affirm the personhood of the baby, who can get lost in all of this talk about statistics, outcomes, and conditions. Priests should also make it clear that continuing treatment, even when survival appears unlikely, is allowable, even if it includes suffering. Now, before I get into the details of my recommendation, I want to give you some more background, both on our situation and on the world into which a micropreemie enters. It was very new to us, but we learned about it very quickly. These are the national guidelines up on the slide here of the American Academy of Pediatrics, which show reasons one might withhold treatment. And reasons include gestational age of less than 23 weeks or a weight of less than 400 grams as reasons that resuscitation would not be indicated. Gabriel was 1 day short of the gestational line. However, he was 652 grams in weight, which put him into the 97th percentile, which, if you can believe, they blamed on me. So this doctor was acting within accepted national standards when he said this. So the next question this poses is, why would the doctor say such a thing? And why would the national standards say such a thing? Well, survival is indeed very difficult for a preemie at this age. Here you can see that at 22 weeks of gestation, 63% of infants died and 73% had died or had profound neurodevelopmental impairment. As you advance a week in gestation, survival rates go up considerably. These statistics are from Japan, which is important because Japan made it standard procedure to resuscitate infants in the 22nd week back in the 1990s. In the U.S., policies have been more haphazard and survival rates are worse, and also there's not as much reliable data available. Doctors are not required to provide care that is futile, which is defined as care unlikely to benefit the patient, or a second aspect, which took me a while to get my head around, treatment to provide poor quality of benefit. This means that saving the patient's life but returning a brain-dead patient to the family means you've provided a poor quality of benefit. There's also a time crunch present here. Our baby was just fine before birth. The problem was preterm labor. So the futility that you're talking about is over a condition not yet experienced when the doctor is making his recommendation. This leads to a situation that some medical philosophers have called a window of death. That is, a decision you can take knowing that it will result in a death even if you are not actively causing that death. In my opinion, this opens a similar temptation to what happens when Down syndrome is detected in the womb. In this country, 67% of Down syndrome babies are aborted, and we were given this similar opportunity to walk away from a potentially disabled child. And I view this as taking advantage of the disabled at their weakest. But that's my view. You also have to think about it from the other perspective with a dilemma this complex, which is, are you perhaps instead reducing the suffering of someone who is likely to die? I'm using this script because I have no hope of staying under time otherwise, because I can go on forever about this. We also have to think about the autonomy of the patient versus beneficence, which is what the doctor must balance in this case without any input from the patient. Imagine a doctor saying to an adult breast cancer patient, you have only a 30% chance of survival, so it's just not worth it. Sorry, no treatment. Or, conversely, if you tell adult patients that they have a fatal condition and a 30% chance of survival with treatment, the treatment would be very uncomfortable. Disability is very likely with survival. Would they all say yes to that? I don't know if I would say yes to that. And that is something that haunted me throughout the course of our NICU treatment, was the level of discomfort we were causing to the baby. One of the primary things that doctors bring to the antenatal counseling session with the parents is statistics. They brought us 4 categories: unimpaired, moderate to severe neurodevelopmental impairment, severe to profound neurodevelopmental impairment, and death. To us, these sounded like dead, almost dead, and life without parole. They also blurred the line between individuals and groups. If there's a 20% chance of survival, and of those only 30% emerge without a disability, does that mean we're going to get 6% of a child? No, you only get one outcome, a child. You're not trying to manage a group. Maybe they are, but you are not as a parent. We found these statistics to be somewhat helpful, but did not provide the information that we really needed to make a decision. We were concerned about our son's quality of life, not his abilities. 2 years after we left the hospital, I was with my wife, able to organize our objections to what happened well enough to write a letter to the hospital's ethics committee. In that conversation, and then they invited us to have a meeting, and in that conversation I found out that the 23-week line in the sand was gone in favor of a method looking at the baby's condition and weight in addition to just gestational age. The doctor in that meeting said, well, we're sorry that you felt pushed, but some families really are looking to let go at that stage. What is something that we can say so that we're not pushing them in either direction? My suggestion was the phrase, your child is welcome in our nursery. And the ethics committee, they all nodded their heads. I'm like, oh, I think that got through. I don't think that introduces bias, but it does make something clear that we were desperate to know at that stage, because all through the 23-week, it was not talked about what would happen if Mary gave birth. And then at 22 weeks and 6 days, we were specifically told that our child would not be allowed in the nursery. And that's not like getting thrown out of daycare, which I should add, that's actually happened to us a couple times. So they also said that after the family and doctor arrive at a decision for what course of care to take, then that decision should be fully supported. And in this case, they said it was not, and they apologized for that. And that meant a huge deal to us to hear that, that they did really want to fully support the decisions. I suggested that they include local statistics along with the gloomy national statistics for survival of micropreemies, and the doctor said, well, we could say that we have a 100% success rate with 22-week preemies. And that made me smack my forehead and say, okay, I see your point. Gabriel was the only one they've had, and it's the largest NICU in the state. Preemies like that are really rare, so there really isn't enough at one hospital to develop those kinds of meaningful statistics. And lastly, in that meeting, I suggested that they include a birth to 3 medical professional, a physical therapist or a pediatric neurologist, and the antenatal counseling to give parents an idea of what kinds of lives the children lead and what kinds of treatment are available for their disabilities. Also last year, I wrote to the American Academy of Pediatrics last year in the summer, and I wrote and asked that they change their rules to be more open to allowing 22-week preemies to be resuscitated. And last fall, they did publish a new guideline. This one being more open to allowing 22-week micropreemies to be resuscitated and putting more emphasis on the parents in making that decision. What's on the screen here at the bottom you'll see is from 2015. The first one I showed you was from 2010, and our son was born in 2012, so you can see where he fell in this progression. I'm also working on an editorial to the Journal of Pediatrics in collaboration with a neonatologist from Florida. And the purpose of this article is to show how families and doctors can learn from each other in this stressful moment. In our case, we believe that we and the doctors were not really talking with each other that well. In my half of the article, I said that ability statistics are okay, but it only shows one spectrum for what families need to make this decision. Anything else based on those ability statistics would have caused us to dig in our heels even further. I also encourage doctors to seek out the motivations of families in making their decisions, asking, what information would make you say yes or no to this question? In our case, it was quality of life questions that were most important to us. If our child were to be severely disabled, was there anything to prevent him from being a happy disabled child? And here I think it would help to hear from other parents of children born this way, either perhaps in written testimonials, how they view their children's quality of life and how they view their own quality of life. And the doctor that I'm collaborating with has, in his part of the article, has said that he thinks that neonatologists could also benefit from this opportunity to challenge their assumptions. Their own assumptions, that is. I also think it's a better question. It's an important question to ask. Which would be better, a short goodbye now in the delivery room, or a strong possibility of one in a week? I think our doctor was trying to save us the grief of a long process in the NICU, but I think we would have felt worse about a child who was not given a chance. Lastly, I'm recommending that the doctors make a point of talking about the baby by name. We knew it was a boy. We had selected the name Gabriel, and Mary was very adamant that our child was not the condition. Rather, she had the condition, which was preterm labor. But the baby was talked about not as a baby, but as a condition and as a gestational age. Well, since this is an Orthodox conference, I can additionally suggest some things for the pastoral care of parents in the dilemma that we were in, and a number of these suggestions do suggest with the more utilitarian ethics that we were hearing. First, we should reflect on our understanding of suffering. We should understand that our suffering enters into the suffering of Jesus, even if someone cannot voice their desire for what action to take. A short life glorifies God, even if it includes suffering, and if we are unsuccessful at trying to save someone, we do not have to view that suffering as sinful. At times when we were in the hospital, we felt as if we were being told that. Second, we need to examine our motivations in making our decisions. First, parents should be willing to accept a disabled child. Also, parents may desire to save their child from the painful treatments of the NICU, but this has to be balanced with the need to protect life. And parents and clergy must always remember that the child is a child, not a statistics. A baby's signs of improving or deteriorating health should be the primary evidence for decisions about whether to continue or initiate treatment. The birth of a high-risk child also presents something of a time dilemma, and we shouldn't base our decisions on fear of the future, and we shouldn't make a hasty decision now to save a difficult decision later. The American Academy of Pediatrics standards make it clear that they consider it ethically equivalent to both withhold treatment at the beginning and as it is to withdraw it later if conditions merit it. So you can make that choice later, says the AAP, and I believe we can also think of it that way. Lastly, decisions to withdraw treatment should be done in consultations with one's spiritual father, and there should be overwhelming evidence that survival is not possible before taking such a step. And I should point out, just so everybody knows, these past two slides I have written all on my own, so I'm not quoting any particular board or anything like that. Lastly, on the topic of pastoral advice, in our own conversations of what to do at that moment, I can say that my wife Mary was resolute that we should go ahead with the treatment. When we got that awful talk from the doctor, I have to admit I was a little bit swayed, and I said to Mary, I'm about 90% with you, but that last 10% I just don't know what to do with, so I called my spiritual father on the phone, and he said, well, listen to your wife. A year later, I went to him again. I was bogged down in the what-ifs, and I was worried about what if I'd gotten the decision wrong, and also worried, well, what if maybe I did get the emergency baptism wrong? It's the only sacrament I've ever performed in my life. I did happen to have a copy of the small book of needs in my bag when he was born, so I was able to at least use the form on page 34 there. So I was going in intending to have this very long, complicated conversation with Father John, but he sidestepped, and he just said, well, Paul wrote that a wife's prayers can save her husband. Lastly, before leaving this topic, I should point out that NICU families do have a pretty high incidence of post-traumatic stress disorder, and they're not getting treated on it. Pretty much, in my discussions with preemie families over the internet and other parts of the country, the hospitals are not reaching out. So if you are looking for some research to do, this could be a topic. Okay, so that first video, it's time for a second video. The first video, I'm sure, was a hard thing to look at. Here's a second video that shows Gabriel at age 3.
You're a very smart boy.
No, I am not. I am a mad boy.
What does that mean?
Hey, I am a mad boy.
Oh, I don't think you're a mad boy. You look like a happy boy to me.
No, I am not happy boy. I am a mad boy.
Okay, so did he convince you? All right, that's the crux of the ethical dilemma, and I am just going to speed straight through these last few slides.
We started late, so
Oh, okay. Well, then I won't. I'll go.
everyone gets 30 minutes.
Okay, thank you.
They'll get a break after this, so there's
Okay. So I spent so much time on the ethical dilemma. I did want to point out that after we got past that, things got a lot better. And we did not have any additional conflicts with the hospital on treatment. And we began a 5-month NICU stay. This is Gabriel 1 week after birth. Those are Miri's hands around him. He's on a ventilator there with a tube down his throat. This is him at 5 weeks old, and the mask that he's wearing is a CPAP mask, which looks more menacing. However, it is far gentler ventilation support that it provides, and so this was progress. This is bath time at the age of 3 months, and here you can see he's starting to fill out and look more like a baby rather than a tiny, wrinkly old man. Here he is at term equivalent, and we caught him giving us a smile, and there he's wearing a vapotherm tube up the nose that provides oxygen support but without any pressure. And Gabriel is now 4. His current condition is that he has a feeding tube for most liquids. He eats by mouth, but for all of his food, but he's stuck on purees. That was Trader Joe's full-fat Greek yogurt you saw him putting into the cart, and that stuff is just wonderful. It's his favorite thing in the world, and it's very high in calories. He has small kidneys, which the nephrologist has diagnosed as stage 1 kidney disease. He's very slender. The nephrologist thinks that's great for his kidneys. The dietitian and the gastroenterologist call him malnourished sometimes. And this is one of the aspects of life of a NICU family, is that you get pulled in different directions by different specialists. He's also speech delayed and goes to developmental preschool. However, they're talking about putting him into regular preschool when he turns 5. I'm not so sure about that, but we're just going to see. And that is the end of the presentation. I would love it very, very much if you can keep in touch with me. I'm on Twitter. I'm on Facebook. I also have email newsletters that I send out once or twice a month talking about my progress towards getting published. This is especially important here with this Orthodox group, just because I live in Seattle. I don't get to fly places very often, so I'm going to be talking to people through computer or on the phone, and so I'm hopeful if you can help me connect to other people in the healthcare and bioethics committee. So I've got these forms up here that you can sign up on. And I guess since this is Ancient Faith Radio, I should point out that the name of the blog is theydon'tcry.wordpress.com. And in the upper left corner of that is a little sign-up form for the newsletter. So thank you.
We do have a few minutes for questions. Do I turn this on? Oh, it's on. Okay, so questions, comments?
I guess the one thing that really, really stuck with me and really bothers me is the fact that that doctor said he would try, but his heart wasn't going to be in it. How do you change that? How do you make a difference besides praying that God is going to be with that doctor? What more can you do to change that, because you don't know where that physician is coming from spiritually?
Yeah, we really don't know. His motivations behind that. It may be. I mean, he was an older doctor, probably. He was semi-retired at that point. But so neonatology has come a long ways just in the past couple decades, from a point where 28 weeks was considered the bottom limit, and that below that there was just no hope. And so he's probably, as surfactant became available, it was kind of this haphazard thing of whether it worked or not. And so, he may have seen a number of poor outcomes that just made him, not want to try again. And I have to accept that as valid experience from him. And we didn't talk with him further about the ethical decision after that. We did talk to the ethics committee of his hospital, and so we're hopeful that he got a nudge in the right direction from that process. There isn't that much more you can do.
Thank you for sharing this. My question is pretty straightforward. Did a clinical ethicist come when that dilemma with the doctor was occurring? I mean, did they have an on-call clinical ethicist in this hospital, or just an ethics committee? Because I work in bioethics, and sometimes there are clinical ethicists who make rounds and come to deal with those dilemmas between a doctor and the family.
No, there was not a clinical ethicist on call or anybody else we could talk to. It was just the neonatologist. The birth happened at 11:20 p.m. And he did show up, and he did do a good job, and he, stopped complaining about it, and he rounded up, which for those last 40 minutes to get to the 23 weeks and 0 days limit, and I'm very glad he did. The hospital does have the ethics committee, I think. As for, other cases, if there's a cancer patient who's, on their way out and the family and the doctor don't agree, is there somebody who can be called in at a moment's notice? I don't know that.
Well, some hospitals do have that.
Yeah.
So my small follow-up was, do you think you would have benefited from a clinical ethicist coming and being on call in your moment of need?
Well, I sure think we would have. But then on the other hand, since, the national standards were against us at that point, how much good would it have done in preserving Gabriel's life? I don't know. Yeah.
Hi. I worked in Brooklyn in the 80s, where we had 24 neonates in the most intensive care, preemies, and then another 24 growing, and another 24 growing yet.
Yeah.
And so we had a ton of experience with preemies. I guarantee you the doctor was traumatized by all the times that perhaps he inflicted harm. We inflict harm when we miss an IV. We inflict harm when we feed too quickly and a baby loses part of their gut. We inflict harm a lot of times unintentionally, and I'm sure many times we have guilt over, did we do the right thing? Because a very aggressive intervention sometimes hurts a baby. So this is before ethics committees, and I guarantee, and I'll only finish with my grandma was born. The doctor told her mother, says she's not going to live. She's too small. So she took my grandma home in a cigar box, put wool around her, and guess what? We've got a big, big family.
Yeah.
One more quick question, and you were next.
Oh, yeah. Thank you. My heart is really full from listening to you. Thank you. As a chaplain fellow, this past year, one of my units was the NICU. And it was just a really powerful experience. I prayed over all the babies, and at least it was very important to acknowledge that parents needed to feel that they were doing everything they possibly could do for this child, and that's their job, including hoping and praying for a miracle. And I found that nurses often were really, really responsive to prayer and often prayed with me with babies, and it was just a really great experience for me, and how protective and loving the nurses were, and I just have so much respect for you for walking through this experience with your love and your faith. And so
Thank you.
We're out of time. Thank you.
Okay.